Okay, so let's discuss the malignant melanoma. So today, malignant melanoma skin lesion. You are given a pathological report. Report shows epidermis and dermis where is a proliferation of atypical non-pigmented epithelial melanocytes at the junction and invading the dermis up to the deep margin. Means that report is showing epidermis and dermis junction, and in the junction there is a melanocyte, non-pigmented epithelial melanocytes at the junction and invading the dermis up to the deep margin. So describe the histopathological features of that report that will indicate poor prognosis. So deep dermal or subcuticular tissue invasion and lymphatic and perineural or blood vessel invasion and ulceration and lymph node metastasis. These all will indicate bad prognosis. So what are the pathological features that indicate good prognosis? Limited tumor depth invasion and no lymphatic invasion. So a definition of a malignant melanoma. Malignant neoplasm of melanocytes or the malignant neoplasm of the melanocytes, melanin producing cells mainly arising in the skin. So this is called malignant melanoma. Other sites, nasal cavities, retina, gastrointestinal mucosa, leptomeninges. What is melanoma pigmented, or why melanoma is pigmented? As the cells of origin is a melanocyte which is pigmented. Since melanocytes are pigment producing cells, so melanoma will be pigmented. Why sun exposure is a risk factor for a melanoma? So high energy radiations and ultraviolet radiation can damage the cellular DNA, directly causing a mutation. So why sun exposure is a risk factor for melanoma? So basically, high energy radiations and ultraviolet radiation can damage the cellular DNA, directly causing mutation. Skin condition associated with melanoma. So xeroderma pigmentosa, dysplastic nevus, multiple nevi, albinism, giant congenital pigmented nevus, and Fitzpatrick skin type 1. So these are the conditions, skin condition again: xeroderma pigmentosum, dysplastic nevus, multiple nevi, albinism, giant congenital pigmented nevus, Fitzpatrick skin type 1 disease. These all are associated with the malignant melanoma. Other risk factors of malignant melanoma are Hutchinson melanotic freckles, immunocompromised patients, past history of melanoma, red hair, sun exposure. Can you describe any systems that aid in the diagnosis of a suspicious skin lesion or microscopic features in the eye or suggestive of melanoma? Means what are the microscopic features in the eye that are suggestive of melanoma? So Glasgow 7-point checklist. So this is the system. Glasgow 7-point checklist are recommended by NICE guidelines. So measure carries 2 points each. Change in size, irregularity of pigmentation, color, and irregularity of outline shape. And minors carries 1 point each. Diameter greater than 7 mm diameter. Inflammation and ulceration, oozing or bleeding, crusting, serosanguinous discharge, itch or altered sensation, tingling, presence of satellite lesions. 2 points are given for each major feature and 1 point for each minor feature. Any score of 3 or more needs to be referred to urgently. So, Glasgow 7-point checklist recommended by NICE. So, change in size, irregularity of pigmentation, color, irregularity of outline. So, whenever this occurs in a nevus, so or there is diameter greater than 7 mm, inflammation, ulceration, oozing or bleeding, crusting, serosanguinous discharge, itch or altered sensation, and presence of satellite lesions. So all these. So for the major, you have to assign 2 points, and for minor 1 point. So any score greater than 3 or 3, refer. This is suspicious. Okay. So what is satellite point or lesions? What is satellite lesion? This is also asked. This is also asked. So remember that the lesions which are lesions which are near the main melanoma lesion or within 1 to 2 centimeter of the melanoma lesions, malignant melanoma lesions which are within 1 to 2 centimeter of a main melanoma lesion is called a satellite lesion. These are actually spread to the nearby area of a skin from the main MM lesion. We will further discuss these as well. Okay, so common comment on the pathology report. What to look for the pathology report? Size, breast thickness measured in millimeter from the stratum granulosum to the deepest point of tumor involvement. Deep depth of invasion. Okay, so Breslow is the thickness of the melanoma measured in from the stratum granulosum to the deepest point of a tumor involvement. Depth of invasion, Clark's level. And ulceration, mitosis, lymphovascular invasion, immunohistochemistry, staining. So all these you have to look in a biopsy report or pathology report. So how to differentiate a melanoma from squamous cell carcinoma? So melanoma arises from the lower layer of the epidermis from any part of the body, tumor of a melanocytes, and squamous cell carcinoma arises from the upper and middle layer of epidermis with keratin pearl formation, usually on sun-exposed areas, tumor of epithelial cells. Needs intermittent sun exposure. Non-melanoma need continuous sun exposure. So squamous cell carcinoma, which is non-melanomatous, this requires continuous exposure, or melanoma intermittent exposure. Arise from lowermost layer of epidermis. Squamous cell carcinoma arises from superficial layer of epidermis. Develops in younger people. Squamous cell carcinoma develops in older people. Elsewhere in the body, anywhere in the body. Sun exposed areas which are continuously exposed, like the hands, face, extremities, anywhere in the body, sun exposed areas, squamous cell carcinoma. Asymmetrical mole with irregular border and multicolored, appears as a red bump, scaly patch, or non-healing sore. Less common, incident more common, metastasis less common, more common metastasis squamous cell carcinoma. Poor prognosis, better prognosis. So you can see here that we have so you can see here that we have the different pictures. So this is basal cell carcinoma, this is scaly bump, and squamous cell, sorry, this one the basal, this is the scaly bump, sore, non-healing sore, which is called squamous cell carcinoma. This is melanoma. Different colored irregular body, and so this one is the melanoma. This is benign keratosis basal cell cancer. Okay, how will you biopsy a case of melanoma? So excision biopsy with 2 mm margin. Okay, what is Breslow thickness? So excision margins for histopathology for histological confirmed melanomas is determined by Breslow thickness. So what are Breslow thickness? So these are excisional margins for the melanoma. So nevus with severe cytological or architectural atypia. So additional clinical margin 5 mm take 5 mm additional margin if a nevus with severe cytological or architectural atypia. So melanoma in situ, so 5 to 10 mm take. Less than 1 mm T1, so always take 10 mm. And less than 1 to 2 mm T2, so always take 10 to 20 mm. Okay, 2 to 4 mm, so T3, so this will be 20 to 30, 20 to 30, and greater than 4 mm, greater than 30 mm, take excisional margin. Okay, difference between BCC and SCC, basal cell carcinoma, squamous cell. So basal carcinoma spread less commonly. This does not spread. More commonly spread. Found deep within skin layers of the thick skin. Found near body orifices in the oral cavity or near the anus, like orifices, or near eyes. Occupies basement membrane. Occupies outer layer of skin. Okay, and like basal cell carcinoma will usually occur towards the basal, stratum basal, and this will occur in the upper parts. 96% of victims 40 years or more. Almost all victims are 40 years or old. Okay, 40 years or older. red pale or palely in color. This is thickened red spot may bleed, crust or ulcerate keratin pearl formation. This has keratin pearl formation. This metastasize early to lymph nodes. Okay. So patient undergoes excision of melanoma of 1 mm thickness and 0.5 mm clean margin. What is the most likely clinical step in his treatment? A wider excision with additional boundary to be determined by the Breslow thickness of the tumor. So in Breslow thickness we know that 1 mm you have to take about 10 mm, 5 to 10 mm. So this is less than 1 mm, so 1 to 2 mm. So 1 to 2 mm, here we have 10 mm. So this means that we have to take 10 mm extra part and excision margin, and here they have taken 0.5 mm. So this is incomplete excision. So this means that a wider excision with additional boundary to be determined by the pressure. So you have to take 10 mm extra excision margin. Which interpretive investigation will assist you to provide a comment on the margin being cleared? So do more micrographic surgery and frozen section. These two will tell you that either the margin are positive or negative intraoperatively. What are the poor prognostic factors in general? So this is for melanoma. So increased tumor thickness or Breslow thickness, increased depth of invasion or Clark invasion, type of melanoma, nodular amyloidotic melanoma. So these are very poor prognosis melanomas. Nodular melanoma, amyloidotic melanoma, presence of ulceration, presence of lymphatic or perineural invasion, presence of original or distant metastasis, male gender and old age. Lesion excised, bristle thickness 1.5 mm, margin 0.5 mm. What to do? Re-excision with 2 cm margin or 10 to 20 mm margin. Okay, so whenever there is a greater than 1 mm, greater than 1 mm, so you have to go for 20 mm, 10 to 20 mm extra excision, and they have taken 0.5 mm, so re-excision. What is the mainstay of treatment of malignant melanoma? So suspicious lesion should undergo excision biopsy. The lesion should be removed completely, as incision biopsy can make subsequent histopathological assessment difficult. So suspicious lesion should undergo excision biopsy. Always and always do excisional biopsy. The lesion should be removed completely, as incisional biopsy can make subsequent histopathological assessment difficult. So you have to take excisional biopsy, not incisional biopsy. Once the diagnosis is confirmed by the pathology report, should be reviewed to determine whether further re-excision of margin is required based on pathology. So you have to review the pathological report, histopathology report, because to confirm whether the margins are positive or negative. So it is positive. For example, inadequate excision, so you have to go for re-excision. Genes responsible for familial malignant melanoma. So BRAF gene. Others are CDKN2A gene, CDK4, MC1R, MC1R gene, and BRCA2 gene. Yes, we have studied in breast cancer station that BRCA2 gene is also responsible for malignant melanoma and pancreatic adenocarcinoma. So BRCA2 gene and BROF gene. Okay, BROF gene is the main gene, and other are CDKN2A, CDKN2A and CDK4 and MC1R. Management, excision with safety margin. Okay, size of the safety margin is based on Breslow thickness. Post excision, the patient developed a regional lymphadenopathy. Management, FNAC of the lymph nodes, okay, and whole body CT to stage the disease to check for any metastasis. This patient has axillary tissue site resected, but subsequently over 24 hours develops a tense swelling in the arm. So like a patient uh, has axillary tissue site resection, and he then develops a tense swelling of the arm. So this means that is axillary vein thrombosis, because um, at one hand it is the malignancy, which is hypocoagulable state, plus there is surgery, so there will be immobility of the arm. So these all contribute to through this axillary vein thrombosis. So explain two reasons for postoperative axillary vein thrombosis in this setting. So now, okay, the same things. Surgery to metastatic melanoma with local tissue injury. Okay, so there will be injury. Surgery to metastatic melanoma with local tissue injury, for example, endothelial injury, with increased local thrombotic tendency. Okay, altered blood flow can occur in postoperative setting in this site. Okay, so and plus malignancy itself is always provide procoagulant or hypercoagulable state. Post-excision, the patient developed a painful swelling of the arm with dyspnea, cause axillary vein thrombosis plus pulmonary embolism. What are the blood investigation in axillary vein thrombosis? Risk of pulmonary embolism. So, blood investigation, arterial blood gases will show respiratory alkalosis of pulmonary embolism. Okay, so blood investigation in axillary vein thrombosis and risk of pulmonary embolism. So arterial blood gases, respiratory alkalosis, if pulmonary embolism, D dimers, if well score greater than 4, pulmonary embolism is likely. CTPA indicated. If well score is 4 or less, pulmonary embolism is unlikely. So, and D dimer is important. If D dimer is negative, likelihood of pulmonary embolism is very low. No need for CTPA. If D dimer is raised, CTPA should be done. And also, because they have also asked that what blood investigations, okay, in axillary vein thrombosis. So, okay, blood investigations. So, okay, what are the differential diagnosis of raised D dimers? So, infection, recent surgery, and malignancy. How to treat DVT? So how you will treat DVT? So acute treatment with parental anticoagulation, low molecular weight heparin, fondaparinux. So, so you have to do acute treatment with parental anticoagulation, for example, low molecular weight heparin and fondaparinux. Maintaining patients on anticoagulation for at least 6 months is the standard practice. Okay, 6 months. And warfarin to keep INR 2 to 3. Standard dose range from 1 to 10 milligram per day for 6 months. So warfarin standard dose is 1 to 10 milligram per day for 6 months. Catheter directed thrombolysis. If clot is less than 14 days in duration, or acute phlegmasia cerula dolens in patients with no contraindication to thrombolytic therapy. Okay, so if the clot is less than 14 days old and there is a acute phlegmasia cerula dolens, means there is a acute swollen and redness of the limb. Okay, so you have to do catheter directed thrombolysis if there is no thrombolytic therapy contraindication. For example, the patient is not of high risk of bleeding. So a clot present for more than 14 days leads to thrombus organization. So if there is a clot which is more than 14 days, so it will leads to organization of thrombus that limits the effectiveness of thrombolysis. Okay, so if you are trying to do catheter directed thrombolysis of a thrombus which is more than 14 days, so it will fail. Why? Because more than 14 days thrombus organization occurs, so there will be no effect. So use TPA, tissue plasminogen activator, continuous infusion of 0.5 to 1 milligram per hour for at least 8 hours, and initial bolus every 6 to 8 hours. Okay, monitor fibrinogen levels, which should be kept above 100 milligram per deciliter to avoid depletion. So you have to also look for you are giving him tissue plasminogen activator, but you have to look for a fibrinogen as well. So because plasmin TPA will convert tissue plasminogen activator plasminogen into plasmin. So plasmin break down fibrin. So that's why you have to keep a check on fibrinogen. So to provide fibrin. So fibrinogen levels below 100 milligram can cause hemorrhagic complication. Okay, upon termination of the procedure, the patient are systemically intercoagulated with warfarin for 6 months. So when you terminate the procedure like this catheter directed or tissue TPA, so you give the patients a systemic anticoagulation for with warfarin for 6 months. Indication for superior vena cava filter placement or failure or contraindication to therapeutic anticoagulation for or for pre-surgical prophylaxis in the setting of substantial thromboembolic risk factors. So, indication for superior vena cava filter placement is a failure or contraindication to therapeutic anticoagulation. So, if anticoagulation fails or there is contraindication to, for example, there is neurosurgical surgery or ophthalmological recent surgery, or there is patient already some like problem, so you have to put superior vena cava filter or yeah. um, okay, so risk factor for thrombosis, Virchow triad, hypercoagulable state, venous and endothelial injury. Management, suspecting pulmonary embolism. So, do CTPA, subcutaneous low molecular weight heparin if the patient is hemodynamic unstable, thrombolysis or embolectomy if massive embolism also. Okay, so they have discussed this in critical care station. So, I can go quickly through this. So, what they say that pulmonary embolism, if the patient is stable and the thrombus is small, so you can give him low molecular weight heparin simply. And if the patient is unstable, and so you can go for a catheter directed thrombolysis or a embolectomy, or if the patient is if the thrombus is massive and the patient is unstable, so also you can go for a catheter directed thrombolysis or embolectomy or a TPA, tissue plasminogen activator, if there is no contraindication for thrombolysis. So all these you can do. Okay, a patient known to, now this is, they have put another stem, a patient known to have hypothyroidism with a hot swelling in her right inguinal region. Her GP sent her for biopsy. What are your differential of this hot swelling in her right inguinal region? So right inguinal region hot swelling. So this can be, okay, so lymph node receives lymphatic drainage from the lower extremities and skin of the lower abdomen, genitals and perineum. Okay, so inguinal lymph node receives from lower limb, genitals, lower abdomen skin, and lower extremities, so and perineum. So infection associated with inguinal lymph node. Okay, so before going to this, we will give the differentials of heart swelling. So the heart swelling can be lymph node, can be tense inguinal hernia, can be fibrous pseudoaneurysm, can be saphenopharynx, which is thrombosed, or it can be any muscle tumor or soft tissue tumor. So, or so there can be any metastasis or lymphoma in the lymph nodes. So all this can be differential. Now, infection associated with the inguinal lymph nodes are cellulitis of the lower extremities, venereal infection, for example, syphilis, chancroid, herpes simplex virus infection, and lymphogranuloma venereum. Okay. Now, malignancy associated with inguinal lymph nodes are lymphomas, metastatic melanomas from lower extremity primary site, and squamous cell carcinoma from genital primary site, and for example, squamous cell carcinoma of the anal canal. So, results of histopathology revealed malignant melanoma. What are the types of malignant melanoma? So, malignant melanomas are divided into 5 main types depending on their location, shape, and whether they grow outward or downward into the dermis. Okay, so location and growth, outward or downward. So, lentigo maligna. Lentigo maligna usually occur on the faces of elderly people. Superficial spreading or flat melanoma grows outwards at first to form an irregular pattern on the skin with an uneven color greater than 70%. Desmoplastic melanoma is a rare malignant melanoma marked by non-pigmented lesions on sun exposed areas. Desmoplastic melanoma, rare malignant melanoma marked by non-pigmented lesions on sun exposed areas. Okay, so acral melanoma occurs on the palms of the hand, soles of the feet, or nail beds. Acral melanoma, palms of the hand, soles of the feet, or nail beds. Nodular melanomas are lumpy and often blue-black in color. Lumpy and often blue-black in color, and may grow faster and spread downwards. Spread downwards. Okay, so this is acral in the nail beds. Acral, this is on the sole of the foot. Okay, so this is acral lentiginous melanoma. This is on the face. Okay, this is on the face. So this is superficial spreading. Okay, which melanoma shows the worst prognosis? Amelanotic melanoma, recurrence during pregnancy. So amelanotic melanoma shows the worst prognosis. Amelanotic melanoma, recurrence during pregnancy. Descriptive term for non-pigmented melanoma. Any type can be amelanotic. 2% of all melanomas are amelanotic. Malignant cells produce no pigment. Poorer prognosis due to delayed diagnosis. What is epithelioid melanoma? Resemble epithelial cells. Melanoma cells can be categorized into two major types, epithelioid and spindle cell. Epithelioid cells are large and round with abundant eosinophilic cytoplasm, prominent vesicular nuclei, and large nucleoli. Prominent vesicular nuclei and large nucleoli. They most commonly arise in the superficial spreading and nodular melanomas. Superficial spreading and nodular melanomas commonly arise in these. What is satellite lesion? Focus of melanoma separated from the main tumor mass, usually visible on the skin surface, often arise as a result of lymphatic spread. Okay, so let's suppose you have this main lesion, okay, and near this lesion there is another lesion, okay, like this. So this is actually the spread to lymphatics. Okay, so they say that focus of melanoma separated from the main lesion or tumor visible on the skin surface often arises as a result of the lymphatic spread or growth of the tumor embolus locally. Growth of the tumor embolus locally. It is a form of local spread of malignant melanoma by contiguity and continuity, leading to pigment spreading to the surrounding area by contiguity and continuity. Okay, how can know the type of the phenotype of the tumor? Immunohistochemistry. With immunohistochemistry, you will know the phenotype of the tumor. Recent histopathological studies of lymph node in metastatic melanoma other than IHC. Okay, so these are genetic mutation studies, BROF gene. If positive for BROF gene mutation, treat with vimoferanib, which inhibit BROF mutation. So, recent histopathological studies of lymph node in metastatic melanoma other than IHC. So you do genetic mutation studies, BROF gene, and if positive for BROF gene, treat with vimorafenib, which inhibit BROF mutation, Okay, so we will make another video.